Okay, thank you everyone again for joining us. Again, my name is Jennifer Wynn. On behalf of the Spectromedics team, I would like to thank you for joining us. As I mentioned previously, we will be discussing New York State DSRIP and the capabilities that your PPS or health system will be needing in order to achieve its DSRIP program goals. So our learning objectives today are as follows. We will start off talking about the key IT capabilities that your PPS or participating hospital might need for implementing a DSRIP program. We will also talk about how these IT components enable a successful DSRIP implementation and address some of the DSRIP challenges. We'll also cover a case study, a comprehensive IT solution for PPS and participating health systems in New York State. And then finally, we will leave some time for question and answer. If you wouldn't mind holding your questions till the end, you are welcome to send them to me via the question feature on your side panel at any point in time. I will reserve those and we will address them when we get to the Q&A section. There will also be 2 pauses within the webinar for polling questions. If you could take a moment to answer those, we would very much appreciate it. It does help us to give you better webinars as we move forward in the future. So without further ado, I will turn this over to Dr. Lockenpaul. Oh, actually, how about I introduce him first? Apologies. Okay, so our panelists today will be Dr. Raj Lockenpaul. Dr. Lockenpaul is CEO of Spectromedics. He's also a member of the National HIMSS Clinical and Business Intelligence Committee, as well as a member of the Board of Trustees for the University of the Sciences in Philadelphia. We're also going to be joined by Mr. Kenneth Atlee. Mr. Atlee is VP for Product Development here at Spectromedics. He is also formerly Vice President of IT Enterprise Operations at AtlantiCare, and he was also CIO for several other healthcare organizations throughout his long career. Finally, we will hear from Mr. Mark Bryant, who is our Senior Account Executive, and he'll be telling you a little bit more about the Spectromedics suite of solutions, and in case you would like some more information there. So now, without further ado, I will turn this over to Dr. Lockenpaul.
Hello, good afternoon. This is Raj Lockenpaul, and it's my pleasure to be presenting part of the webinar to you. The DSRIP program is still a program in evolution. The Department of Health has laid down many processes, and especially around consolidation of data and providing data to the various PPSs. The data, the file for the initial attribution member file was received by the PPSs in late July, and that has limited capability to do analytics. It's an attribution file that was provided by the DOH, while the DOH performs an opt-out process for the Medicaid members. So the claims file that is needed to do analytics or needed to start the process is still not available. The baseline year will be 2012, and the 2012 Medicaid claims file will probably be available soon, and the attribution or the opt-out will be completed by the end of the year. So a lot of moving parts that are being addressed. The Medicaid Analytics Provider Portal, which is MAP, which is the 4th bullet on the top of this thing, is still in the planning and the design phase. So a lot of moving parts, things are moving, and the PPSs are gearing up to provide the services that they need to do. Next slide, please. We believe that there are about 6 essential IT components that a PPS and a participating hospital health system needs to be successful in DSRIP program. A number of the people on the webinar are from health systems, and you will find that there is significant commonality between what a PPS needs to do and what a health system needs to do. So we'll talk about those as we go through the webinar. The first one, obviously, is building a secure, extensible, and cost-effective IT infrastructure. This is a 5-year program, so you don't want to be investing for the next 20 years. The ability to collect and aggregate data into an enterprise data warehouse is critical. The claims data would be the first data set that you will receive as PPSs, integrating that in time with clinical data, with HIE data, with care management data to create a longitudinal patient record would be very good and important. So that needs to be done. The next step is obviously doing analytics, and analytics to identify high-risk patients, identify patients that are at high risk for being readmitted to the hospital, for being admitted to the hospital, or at high risk for utilization. Either they are high utilizers or they are low utilizers, but will end up being high utilizers in time is critical. And all that will lead to more effective care management and care navigation. So the fourth square, Nathan, is around near real-time information exchange for effective care management. So identification of patients, collection of data, identification of patients, and then effective care management, care coordination. For a PPS to be successful, they will also need to provide measures to the Department of Health, and they will get report backs from the DOH in over 3 to 6 month time periods. And they need to be tracking those measures that they have committed to the DOH on a more regular basis, maybe on a monthly basis, on a fortnightly basis, or monthly basis, so that they can improve, they can identify gaps in care and improve those measures. And the sixth one is obviously very good care management, care navigation, care coordination capabilities. Next slide, please. So we are fortunate to be working with the PPS and health systems that are part of the DSRIP program. And based on our experience over the past 3 months, we will be presenting to you what we feel is critical and what needs to be done in the near term and the longer term. Our experience is based on a PPS in New York State, which has 2 co-lead hospital organizations. They have 80,000 Medicaid members and about 1,000 providers, which are physician practices, FQHCs, health homes, health systems, hospitals, SNFs, behavioral health, and community organizations. They were formed to address, this PPS was formed to address the needs of a region, and they did not have any IT infrastructure prior to their formation. And their objectives are create an integrated source of DSRIP information for analytics and reporting, improve population health, reduce hospital readmissions, calculate and track DSRIP measures, and enhance care management and member engagement. Next slide, please. The other is a hospital health system that's a co-lead within the PPS. It has 400 beds, 2 campuses, one in main campus, and the other is a behavioral health campus. It has 19,000 annual admissions and 66,000 ED visits. They have a hospital inpatient EMR that is ME2 certified. They have a separate EMR for the emergency department and separate one for their clinic. And one of their main issue was when we met them for the first time, that they see patients in the hospital. They see patients in the clinic every week, Medicaid patients, and then they see those same patients in the ED. But both systems don't know, they don't communicate. So one of the issues they were addressing for them is to make sure that they are able to know how patients are seen in the ED and the clinic. But also, and then they have an ambulatory EHR, which is separate, and then their providers are on separate, disparate EMRs. So that's the ecosystem they have. If you look at the objectives, they're very, very similar to those of the PPS. Create a single integrated source of information, reduce readmissions, reduce admissions to the hospital. Obviously, for them, improving length of stay and HACs, hospital-acquired conditions, would be very important. Calculate and report on quality measures or measures that they have agreed to, and then improve care coordination, care management, and obviously identify the high-risk patients. Next slide, please. I'm now going to pass this to Mr. Kenneth Attlee.
Okay, thank you, Raj. At the heart of a PPS IT infrastructure is an enterprise data warehouse where data from multiple sources is aggregated and stored in a manner that supports both population analytics and PPS performance management and improvement initiatives. Medicaid claims and member attribution data supplemented by member clinical data from provider EHR systems needs to be collected, normalized, and integrated into the EDW. Lead provider health systems can also contribute a richer data set for their Medicaid populations to the PPS. Data supporting care management also needs to be collected, consolidated at a member level, and then distributed to the care managers for all the members' care management or care team providers. Analytics and reporting requirements requires a comprehensive suite of applications such as predictive modeling, performance measures, reporting and tracking, and data visualizations. Health systems today need essentially the same IT components to support DSRIP and other incentive and value-based programs for Medicare and commercial patient populations. Health systems must contribute clinical data to HIEs on an ongoing basis. In New York State, regional HIEs will collect clinical data from PPS participating providers and transmit the clinical data for attributed Medicaid members to the appropriate PPS. Population health intelligence, data visualization tools, and quality measure performance tracking and reporting are capabilities that all health systems need, especially for participating in a DSRIP PPS. And Jen, do you want to take over the survey?
Absolutely, sure. Sorry about that. Okay, great. So it is time for our first survey, and we would like to know, what do you see as the most important need for your DSRIP program implementation? So we'll give you a couple of moments to answer that question. There we go. And we will be back in just a moment with the results. Okay, I think we have enough time there, so if you can close that poll. Okay, great. And we have our results presented on the screen here. It seems an enterprise data warehouse model for DSRIP data seems to be the most pressing concern, followed closely by capability to manage and reduce preventable hospitalizations. Wonderful. Thank you very much for taking the time to answer the polling question. And from here, we will move on to our next speaker.
Thanks, Jen. I'm actually still going to continue here. First and foremost is privacy and security. DOH has come out with a set of 12 workbooks relating to system security plans that every PPS is going to need to address. The secure role-based access and authentication and a lot of policies and procedures really need to be put together initially before actually any of the data is allowed to be released. The information infrastructure is really critical to provide meaningful, actionable information to support the delivery system reforms. The technical the information is really critical also for planning a lot of the clinical integration and the care coordination and quality improvement projects that are going to be taking place within the PPS. Continued cost-effective DSRIP operations need to be supported over the 5 years of the DSRIP program and well beyond. Each PPS has been asked to provide input, and New York State DSRIP program had to submit to CMS what their sustainability model was for after 5 years. It's in the state of New York. It is going to be a value-based purchasing model, very much like the Medicare VBP program. So the processes and the structure and the infrastructure, everything that's going on today, it has to be leading up to the point where the providers in the PPS and the PPS itself have to be geared towards really a value-based purchasing program in the future. Addressing privacy and security and assuring DOH of the PPS's ability to protect the confidentiality of the Medicaid data is both the initial hurdle as well as the ongoing challenge. There's a lot of assessments, mitigation, vulnerability tests. All these things really need to be provided on an ongoing basis to really ensure that the data is secure and confidentiality is maintained. All the IT industry best practices need to be considered and built into the infrastructure and the PPS culture, backed by extensive policies and procedures. DOH has imposed very strict mandates before any of the Medicaid data can be shared or even accessed outside of the PPS. The opt-out process to allow members to not allow their medical data to be shared by providers, that has to be completed, as well as completion and approval of a lot of these assessments, affidavits, and system security plans have to be approved by DOH before the Medicaid data can really be put into the ultimate or the infrastructure that will be used on an ongoing basis. As we've talked about, and as your survey sort of backs up, the enterprise data warehouse is really key, and a PPS needs to have a comprehensive data management capability, including a very good ETL process, or a process for extracting, transforming, and loading data into a data warehouse. And as we've mentioned previously, the data warehouse it has to be modeled specifically for today's healthcare ecosystem. A key component, obviously, is the enterprise data warehouse and it should have a patient-centered clinical data repository. Comparative benchmark data sets must be available in the data warehouse, and master data sets are required to support comparative analysis for tracking measures and improvements which trigger incentive payments. Also, a PPS needs to apply good data governance, data quality, business rules, and error processes to make sure that the data is clean and accurate before it goes into the data warehouse. And as we've mentioned before, these capabilities that the PPS needs are really capabilities that all health systems today really need to have in place to support not only DSRIP but other populations like ACO populations and Medicare shared savings programs. And I'll turn it back to Dr. Leckenpaul.
Thank you, Ken. So as Ken mentioned, the two, well, as Jen told us, that the two main needs for our participants are an enterprise data warehouse and ability to reduce preventable readmission. So Ken has talked about EDW. From a clinician's perspective, at a high level, the data needs to claims data, clinical data, HIE data when available, hopefully sooner than later. And other data sets, clinical data could be from your clinics, could be from other providers, and care management data in time. If they all flow into an EDW and get normalized into a longitudinal patient record, that is very, very good. That's very good, and that becomes the basis of population health intelligence. And our view of population health intelligence is that the most important part of that, if you can point to the first arrow, Nathan, is reducing preventable readmissions. So, and especially with the primary goal of the New York State DSRIP program is to reduce avoidable hospital use by 25% over 5 years. So identifying members at higher risk for readmission, identifying members or patients at higher risk for admission. Second is members with chronic conditions and diseases, identifying gaps in care, significant gaps in care there that can lead to an admission or a readmission, and to facilitate comprehensive care management and care coordination. And the third goal, which maybe can be addressed very quickly once the PPSs get the claims data, is to identify members with highest or lowest service utilization. So members that are super utilizer or utilizers of Medicaid services, and then members who, Medicaid members who may not be super utilizers, may be utilizing services not as efficiently or as much as needed, but could potentially become very high utilizers in the coming year. So that's the main goal of the entire modeling, predictive modeling, and stratification. Another important area for analytics is also to identify providers that may be high utilizers of services, or providers with significant referrals or significant costs as well. Now, if you look at what we will do here, or what needs to get done, the health systems also need very similar processes in place, or applications in place, not only for DSRIP, but for their ACO programs, for their, as they go at risk for bundle payments and other programs as well. Next slide, please. Population risk stratification and reducing preventable admissions, hospitalizations. So it's around calculating a risk score, creating disease registries, and analyzing past and forecast future services utilization costs. And I mentioned all of those points in the previous slide. From a PPS perspective, data visualization and reporting for geomapping and hot spotting is important of chronic diseases. Or, you know, for example, at one of our clients, or one of the areas we were discussing recently, is you geomap or you hotspot and find out that a certain project has a greater propensity for behavioral diseases and substance abuse. you may need to dissect further or have further analytics to identify further. So ad hoc analysis and report on-demand information will also be required as you move onto this journey. Next slide, please. So let me take a minute to talk about both population health models and also risk stratification for high-risk patients for readmissions. So the commonly used models have been based on DRGs and has generally been used by payers to make payments based on the risk stratification of patients or the consumption of resources designed by payers to define which risk categories are paid at a higher rate. The HCC, is the CMS model. ACG is the Hopkins model. The elder risk assessment is for patients over 60 years of age and it's based on claims and administrative data and accounts for admissions to the ED as well as the hospital. CCC, chronic comorbidity model, the Charson Comorbidity Index, they are based on comorbidities. The MN tiering is the Minnesota tiering, which is a Mayo Clinic simplification. They've simplified the ACG model there. And the LACE model is a model that is being used currently based on claims data, or it was developed using claims data to identify high-risk patients for readmissions. It's the starting point for any risk model you develop for readmissions. LACE stands for its length of stay, acuity, Charlson Comorbidity Index, and the emergency department visits. But there are many other models there for readmissions, the IHI model, that Institute of Healthcare Improvement model that takes into consideration prior readmissions. And there are many models that are also there. But the LACE, keep in mind with LACE, generally it gets more accurate at the last day of the admission. So it's not a model that can be used in the earlier days of admission. And the R-square of LACE is in the 30% range. So it's a fairly, it's not a model that's very, very sophisticated. So that's one place where Spectromedics is, next slide please. That's one place where Spectromedics really has excelled at, and we have built a model that looks at the zone of improvement, which we look at high-risk patients and very high-risk patients. And we have done this by looking at, we have done this by looking at patient demographics, by patient sociographics, medical history, claims data, and clinical data. And really built with that, created a zone of improvement in our readmissions model for high-risk and very high-risk patients. And there, I wanted to take a minute to explain this graph to you. If you look on the left-hand side, it's low-risk patients, medium risk, high risk, and very high-risk patients. The low-risk patients, out of the 5,500 odd patients, only 289 were readmitted. Whereas in the very high-risk category, out of about 1,800 patients, 1,828, a significant number were readmitted, 569 were admitted. So in the low-risk model, only 5.3% were readmitted when we back-tested our model. In the high-risk patients, 31.1% were readmitted. If you combine the high risk and the very high risk, out of about 30% of the patients, 30% of the patients accounted for 60% or close to 2/3 of the readmissions. So model is very sophisticated. It takes into account not only the LACE components, the boost components, the IHI models, but also takes the social and the economic factors into consideration as well. And that's one of our key differentiators. Next slide, please. I think a lot of this is probably repetition, but identifying high-risk patients, care gaps, and medication non-compliance, again, is critical as we evolve into population health and into risk stratification. Next slide, please. Another important component of the DSRIP program is to every PPS has identified certain measures that they're reporting to the Department of Health. In our case, our PPS is reporting about 70 measures, about 70 plus measures, between 70 and 80 measures that they have to report. And the Department of Health will then calculate, and results will be accessible via map after 3 to 4 months. The PPS needs, and the PPS will be paid based on their compliance and adherence to those measures. So PPS needs the capability to be able to calculate and report and identify gaps in care to those measures on a more regular basis, more near real-time basis, maybe once a month, so that they can improve, they can make significant improvements before the data is submitted to the state and before the data is reported back to them. They also need some way of validating the Department of Health calculated measure results and map as well. If you look at health systems, they will need to do the same, but also along with that, they will need a measures calculation reporting for various quality reporting programs like meaningful use, HIQR, PQRS, ACO measures, different kind of measures. Next slide, please.
Okay. Thank you, Dr. Lockenthal. Okay, we are on to our second survey question, and that is simply, do you currently have a solution for your DSRIP program? So we'll give you another 30 seconds to answer that question, and we will be right back. Okay, I think that's probably enough time. Nathan, would you close the poll? Okay, so the majority of you do not have something yet, but it's good to see that some folks are proactive, and we're already 26% of you are underway with a solution for your program. So that's great, and we'll turn it back over to Dr. Lockenthal.
Great. Actually, Jen, this is Mark Bryant. I will take it from here.
Sorry about that, Mark.
No problem. So thank you, everyone, for attending. I'm going to talk a little bit about the benefits of our Spectrumetics DSRIP solution, both for PPS and for our participating health system. So number one, we can create that single source of truth needed for DSRIP projects and population health intelligence. We can identify opportunities to reduce costs and improve utilization with our predictive modeling and data visualization tools. Overall, we can help improve performance results across the whole delivery system, and our solution can enhance care management and member engagement. Next slide. As Ken had showed previously, this is how we can create an IT and performance reporting platform for a PPS. The first step is creating that enterprise data warehouse, where we're able to integrate in the Medicaid claims data. We can integrate in a participating hospital data sources. We can also build for a participating hospital a data warehouse as well if they do not currently have one. We can integrate in the RIO, the HIE data sources as they become available, and also any care management system data we can integrate into the enterprise data warehouse to give that one source of truth. Once we have that one source of truth, we can layer around that the measurement platform for reporting on the DSRIP project measures. We can then do also the predictive modeling and analytics for them as well. And then the third state is how we output it out. So we can give the ability for PPS to have performance reports and actionable alerts. We can also report out directly to the state on the measures that are specific to the PPS, the participating health systems project measures. Next slide. So overall, our value proposition is we can integrate disparate data to create the state-of-the-art data warehouse by populating with Medicaid claims and provider clinical and care management data. We can offer the predictive modeling and analytics and reporting platform to support any care management initiatives. our system can be quickly implemented for utilization and cost analysis, risk stratification, and care coordination. Our measurement platform is ONC certified. We're able to calculate, track, and report on the measures that are specific to each PPS's DSRIP projects. We can offer data visualization tools for creating those reports and dashboards and identifying trends and opportunities. That can be done as CAN reports or also as ad hoc reporting system. We can customize dashboards specific to the DSRIP project measures that each PPS is participating in. We have the ability to generate data and reports directly back to the DOH for submission on performance matrix. And our solution is an outsourced solution, which means it's minimizing the overall IT overhead for the PPS or the health system participating. Next slide. And to summarize, we believe the SpectrumEdX solution addresses the key IT components that a PPS or participating health system needs to be successful. Our solution augments care transitions and the management of care with predictive analytics and information sharing. We have the experience. We're working with the PPS and the health system lead provider today. Thus, we understand and are ready to solve the challenges of a DSRIP, including the immediate need to reduce preventable readmissions, the lack of data from the state today, and complying with privacy and security requirements. And with that, I'm going to turn it back over to Jen for our question and answer segment.
Okay, thank you so much, Mark. All right, I actually just put something over into the chat feature over here. If you have any questions, feel free to enter them into the side panel. There's a little tab that says questions. We did have a couple of questions come through, and I wanted to address those first. First off, we did record this presentation, so we will be making that available to you, and we will be sending out an email on how you can obtain that as soon as that is ready for you. So just wanted to address that. I have had several people ask. I also did want to relay a question. What do we have here? Okay. Of key IT components, which do you think is the most important? Ken, I think that might be something that you could answer.
Sure. Well, I don't know if there's one in particular, but I think the combination of all of them is really what's important. As the survey shows, the enterprise data warehouse and the predictive analytics for readmission risk are really the two that come to mind. But really, it's the combination of all those components that are going to be required at some point in time. Most importantly, as quickly as possible, to really stratify the population, to understand the utilization and cost patterns of the population, and really make have the ability to put in place the tracking mechanism for those projects and their measures that is really going to be triggering the incentive programs in year 4 and 5.
Great, thanks, Ken. I actually think that I had two questions that were very similar, so I will let Ken address this as well. But the first is your solution secure cloud-based, and how is access enabled? And the other is this predictive modeling solution a cloud-hosted solution, or does it need to be installed on premises? So I will let you take that over, Ken.
Yes, for a lot of reasons, mainly for the privacy and security concerns, and really to have a cost-effective IT infrastructure for a PPS. We've selected, and I think a lot of the PPSs in New York that already selected an IT infrastructure have gone to a cloud-based solution. We think, and our experience has been not only with DSRIP programs, but for our other clients, for a lot of reasons, it just makes sense today. And I think the IT industry and healthcare in particular is really starting to realize that cloud-based hosting solutions are really very cost-effective, especially when the amount of capital and operating revenue, or the operating sources that are available to IT departments is really dwindling. So yes, all of our solutions are cloud-based. We provide all the managed services around the cloud as well. There's very little that a PPS or a health system really has to do other than supply the data source or make it available for our ETL tools to reach in and pull the data. And on the output side, we use a lot of mechanisms to actually push information, actionable information, interventions and such directly to the care team members through various media and sources. And I just saw another question which is related, which is
it a private cloud?
Is it a private cloud? Yes, it is a private virtual cloud. We have gone through a number of RFP processes to identify those cloud hosting vendors that really address all of the privacy and security concerns and best practices. We've ruled out many of those, and we're actually in the process of migrating to some of the newer offerings that have a lot of capabilities and a lot of managed services that wrap around and supplement what we provide.
Great, thank you, Ken. All right, it doesn't appear that we have any additional questions ready for you, so I think that is it for today. But thank you all very much for joining us. If you have any questions that crop up after this, by all means reach out to us. And actually, Nathan, if you can advance the slide, I think it has our contact information on it for you. There you go. That would be me, Jennifer Wynn. Feel free to reach out to me either via phone or via email. I will make sure that you get in touch with the appropriate person here at SpectrumEdX. Thank you again for joining us, and enjoy the rest of your afternoon.